Okay, so in this particular session, I'm finishing off the lesson on meningitis. So this is basically meningitis part 2. So in the previous lesson, I had started looking at the management of suspected meningitis. So this is basically the management, and as nurses, we need to be um, fully aware of the management approach to meningitis because we are key members of the healthcare team. So whether or not they're going to do a lumbar puncture will be dependent on a number of factors which you need to assess together with the attending physician, of course. So normally we don't want to do a lumbar puncture in a patient with a raised intracranial pressure. And so we assess if a patient has a central nervous system lesion, such as a brain tumor. This is a patient who might have increased intracranial pressure. History of CNS trauma, okay, there might be a lot of cerebral edema there, and there could be increased intracranial pressure. So head injury patients, these are not candidates for lumbar puncture. If a patient has a CNS shunt, also we may suspect that this patient could have raised intracranial pressure, and with us would try to avoid performing a lumbar puncture in this patient. Also, patients with coagulopathies and patients with hemodynamic instability. For such patients, it may not be desirable to perform a lumbar puncture. So if any of these are present, what we'll do is we're going to go on. This is for for suspected meningitis. So we'll go on, and for bacterial meningitis in particular, we want to administer dexamethasone because remember the pathophysiology of bacterial meningitis is such that the body's immune response to the presence of bacteria actually causes more harm. Remember that it was the microglial cells, our own immune cells, that produced these reactive oxygen species that began to destroy endothelial lining, etc. So we want to uh, give an anti-inflammatory in the form of a corticosteroid. So dexamethasone would be preferred 0.15 milligrams per kg body weight. That is if it is indicated, okay, particularly in bacterial meningitis. And then we begin empirical antimicrobial therapy. So normally we can give, or the patient will be put on vancomycin 15 milligrams per kg body weight intravenously, plus cefotaxime 100 milligrams per kg IV, or ceftriaxone 50 milligrams per kg IV. Normally, this is a patient who will be admitted to ICU, and once the raised intracranial pressure is corrected, then lumbar puncture can be done. Or if the coagulopathy is corrected, then lumbar puncture can be done. Or if the patient now becomes hemodynamically stable, then we can do a lumbar puncture. But if there were no contraindications to lumbar puncture, then the moment we collect blood for these other serological tests, we go on to perform a lumbar puncture. And then immediately after we perform the lumbar puncture, then we can commence this therapy with dexamethasone and antibiotics. Okay. So in the acute phase, we need to monitor the airway, the breathing and circulation. We need to monitor oxygen saturations, and we need to make sure that our patient has IV access. The patient may have to be intubated depending on the degree of the respiratory distress which they may experience secondary to this condition. And then droplet infection precautions will have to be taken in the case where our patient has an infection with Neisseria meningitidis. Sorry, there's supposed to be an M there. It's Neisseria meningitidis infection because it's highly contagious. Then I have already described the empirical antibiotic therapy. Of course, we'll add dexamethasone, as already explained, and then cefotaxime and vancomycin. If our patient is greater than 50 years old, remember that this is a patient who will be susceptible to Listeria monocytogenes, so we want to add ampicillin 2 grams IV 4-hourly, just to make sure that we cover for Listeria monocytogenes. Then if this is a patient that has neurosurgery or trauma or a CSF shunt or a basilar skull fracture, or basically head injury patients, we want to give 2 grams IV 8-hourly. Then we also add vancomycin. If this is a patient with herpes simplex virus encephalitis, then we want to make sure that the patient is receiving, they may be prescribed a cyclovar 10 milligrams per kg body weight 8-hourly. I have also provided for you a list of specific antibiotics for specific microorganisms. So if we're dealing with strep pneumoniae, which may be common in young children and also young adults, this patient most likely will respond to penicillin G, that's benzylpenicillin, or ampicillin, okay? This patient will also respond to ceftriaxone or cefotaxime plus or minus vancomycin for 10 days. If it's Neisseria meningitidis, also common in young adults, this is an organism that will respond to ceftriaxone, benzylpenicillin, or ampicillin for 7 days. And in most cases, they're using a cephalosporin in the form of maybe ceftriaxone, or in its absence, cefotaxime. Listeria monocytogenes will respond to ampicillin, penicillin G, plus gentamicin for 14 days. So you will notice in most cases, if it's a neonate or the very old, they may want to add ampicillin or gentamicin to the treatment, depending on the assessment. Then Haemophilus influenza will respond well to ampicillin, ceftriaxone, or cefotaxime, and then Enterobacteriaceae will also respond to ceftriaxone or cefotaxime. So if you look at the antibiotics provided here, you'll notice that cefotaxime and ceftriaxone are effective for quite a wide range of microorganisms. So it is for this reason that they are quite commonly prescribed to patients with suspected bacterial meningitis. Okay, for fungal meningitis, it will be amphotericin B or fluconazole or flucytosine, or a combination of maybe amphotericin B and later on fluconazole. We may need, in the case where there is cerebral edema, we may need to administer mannitol. And then, of course, the patient will require analgesics and antipyretics for the treatment of the headache and for the fever. So they'll require, we may have to give them some acetaminophen. Then we need to administer an anticonvulsant if necessary, such as phenytoin or phenobarbital. Patient needs to be on bed rest until neurologic irritation improves. How do we nurse this patient? So I put a nursing management using Henderson's model of nursing care. Now remember that when Henderson describes the nature of people, Henderson says every person, regardless of where they are in the life cycle, they have 14 fundamental needs which they need to be able to meet. So for a patient with meningitis, we want to assess to see whether they are able to meet these 14 fundamental needs. So to begin with, to breathe normally, will this patient have a problem? So a patient with meningitis will have risk for ineffective breathing pattern related to possible development of seizures and generalized weakness or prostration. Okay, what about to eat and drink adequately? The patient may have nausea and vomiting, leading to reduced desire to eat and drink. Then what about nutrition? So because they are unable to eat properly due to the nausea and vomiting, the patient may have nutritional imbalance less than body requirements. What about to eliminate body waste? The patient might have constipation related to inactivity, okay, because they'll be on total bed rest or they'll be prostrated, they'll be severely weak, and so they'll be unable to move around, so they may develop constipation. The patient may have impaired urinary elimination, so they may have incontinence or retention of urine. This may be related to impairment in neurologic sensing and control, because if parts of the brain that are responsible for maintaining voluntary bladder control are affected by the meningitis, then your patient might have incontinence. Okay. Bowel and urine incontinence, of course, that will be related to impairment in neurological sensing and control, and it may also be related to transitions in nutritional delivery methods, where we're giving perhaps very fluid diets, and that might cause our patients to we're giving this diet that is very fluid and it is low in fiber. Our patient may end up with constipation. Then to move and maintain desired posture, the patient will be unable to move and maintain desired posture because of neck stiffness and headache related to meningeal irritation. Then what about to sleep and rest? The patient will be unable to sleep and rest adequately because of pain, which basically is headache, and then irritability that will occur as a result of the meningeal irritation. What about selecting suitable clothing? Okay, this patient will be unable to select desired clothing and dress accordingly due to altered levels of consciousness. Also, the neck stiffness will impair their ability to dress themselves. Painful spastic hamstring and other muscles will also impair the ability of these patients to dress the way they would want to dress on their own. Restriction of choice of clothes related to pain and disturbed sensory perception. So these will be problems with meeting this particular need. To maintain body temperature within normal range, the patient will have inability to maintain body temperature within normal range due to the infectious process and increased metabolic rate and dehydration. Okay, and then to keep body clean and well groomed, the patient will be unable to keep body clean and well groomed owing to fatigue and also altered levels of consciousness. What about to avoid changes in the environment or to avoid injuring others? This patient will have risk for injury to self related to disturbed sensory perception and general body weakness, as well as seizures. The noise in the environment may lead to seizures and self-injury. Then this patient will have inability to tolerate bright lights in the environment related to irritation of the meninges around the optic nerve and also cranial nerve number 5. Then to communicate with others, the patient, of course, will have inability to communicate effectively related to interrupted family processes and altered levels of consciousness. What about to worship according to one's faith? This patient will have inability to worship according to their faith because they are hospitalized and they are in isolation, if at all they have meningococcal meningitis, because there is no privacy in the hospital setting, so they may be unable to worship according to their faith. What about to work in a way that there's a sense of accomplishment? This patient will have inability to work, and of course, this will be related to altered levels of consciousness. The patient has photophobia, they have headache, neck stiffness, neutral rigidity, and they have general body weakness. So this is a person who really cannot work effectively to accomplish what they desire. What about to play and participate in recreation? This patient will have inability to play and participate in recreation related to disturbed sensory perception. Okay, they have vertigo, they have general body weakness, pain, of course, they'll have headache and hospitalization. So they'll be unable to play. What about to learn and discover and satisfy curiosity? They will not be able to learn effectively because of altered levels of consciousness. So the problems identified from this analysis that we've given are that there's altered cerebral tissue perfusion, there's ineffective breathing patterns, risk for injury, deficient fluid volume, hyperthermia, risk for impaired skin integrity, acute pain, knowledge deficit. And then if we are to make some nursing diagnoses now out of these, we can see that the first one would be altered cerebral tissue perfusion related to increased intracranial pressure and cerebral edema. What would be the evidence? Patient might be delirious, or they'll have hallucinations, drowsiness, and hypercapnia, or simply evidence might be altered levels of consciousness. That will be a sign of altered cerebral tissue perfusion. Then ineffective breathing patterns, these will be related to seizures. Okay, you know that when a patient convulses, oftentimes their airway will be compromised. And so patient will have ineffective breathing pattern related to seizures and generalized weakness or prostration. This ineffective breathing pattern may be evidenced by hypercapnia and cyanosis. Okay, risk for injury related to confusion, seizures, and restlessness. Then the patient will have a deficient fluid volume related to nausea and vomiting. They'll have fever and also septic shock. Remember that a risk problem or a potential problem, when we state it in a nursing diagnosis, it will not have evidence. So also there will be risk for impaired skin integrity related to immobility and petechial hemorrhages, okay, especially with meningococcal meningitis. So let us now draw up a plan to care for this patient. So the first problem here is altered cerebral tissue perfusion. What will be our nursing diagnosis? It is altered cerebral tissue perfusion related to increased intracranial pressure and cerebral edema, evidenced by altered level of consciousness generally. Then the objective will be that client's cerebral perfusion will improve within 2 days of admission, as will be evidenced by eupnea. Eupnea is just normal breathing pattern, and then normal oxygen saturation and normal Glasgow Coma scale scores. So in this objective, you can see I have actually indicated what the evidence of achieving this objective should be. What will be the interventions and their rationale? We'll need to monitor the patient's neurological status using the Glasgow Coma scale. We'll check vital signs and we'll check oxygen saturation frequently and compare with baseline to assess trends and take prompt action. So you can see this has the actual intervention and the rationale. Why are we monitoring the patient? It is so that we can assess trends in the patient's condition so that we can take prompt actions. Then we want to elevate the head end of the bed at 30 degrees in order to avoid neck flexion and hip flexion, and also to promote venous drainage from the head, thereby reducing cerebral congestion and edema and reduce intracranial pressure. So we are intervening to reduce or to alleviate or to correct the altered cerebral tissue perfusion. Then we're going to administer oxygen therapy as it reduces hypoxia. So we know that hypoxia increases blood volume, promotes cerebral vasodilatation, and it elevates intracranial pressure. When your patient is very hypoxic, in a case where a patient has increased cerebral intracranial pressure, one of the remedies that we do is to administer high flow O2. So we just give a lot of oxygen to the patient. Remember that carbon dioxide in the central nervous system will lead to cerebral vasodilatation. So we want to reduce the amount of carbon dioxide in the central nervous system so that as the levels of carbon dioxide reduces, then the level of vasodilatation will reduce and we'll try to reduce the intracranial pressure. Then we'll administer osmotic diuretics as prescribed. This can be mannitol 20% at 1.5 to 2 grams per kg body weight over 30 to 60 minutes. This will be done to reduce the intracranial pressure.
Then we will need to administer prescribed corticosteroids such as dexamethasone. It can be 10 milligrams IV QID for IV 6 hourly or QID for 4 days. This will reduce inflammation and it will reduce intracranial pressure. What will be our evaluation? So after we put in these interventions, we evaluate the patient and we may find that patient cerebral perfusion improves within 2 days of intervention, evidenced by normal breathing pattern, that is eupnea, okay, normal oxygen saturation, and normal Glasgow Coma Scale scores. Another problem that we've tackled in this particular plan is risk for injury. So we're saying the patient has a risk for injury. This is a nursing diagnosis. Risk for injury related to cerebral irritation, focal edema, and ventriculitis. Okay. Um, what will be our objectives? Patient will be free from falls and injury throughout hospitalization. What will be our nursing interventions? We need to nurse this patient in a padded railed bed, as we do with all patients that are susceptible to seizures. We put them in a padded railed bed so that even if they have seizures, they convulse, they will not injure themselves. They will not fall off the bed, and as they bang onto the rails of the bed actually has pads that will cushion the impact. Then we'll need to ensure that the patient is not left alone from close monitoring in case of a fall. Then we need to administer prescribed anticonvulsants. This can be diazepam to prevent convulsion and reduce the risk for injury. We need to provide a quiet environment that is free from bright lights, and we need to minimize handling the patient so that we can allow for periods of rest between care or procedures. All these measures will help to reduce irritation of the patient that may stimulate seizures. So we want to make sure the environment is quiet because noise can stimulate seizures. We want to make sure the lights are dim lit. This is a photophobic patient, remember? So we want to make sure the lights in the room are dim lit to prevent photophobia and also irritation. We may evaluate the patient and find that patient is free from injury throughout hospitalization. Okay, so then you can look at the other problems, the other nursing diagnosis, and see how you can come up with interventions as you go through the lecture notes. Think of ineffective breathing pattern. How are you going to manage this problem? Okay, think of the deficient fluid volume. How should this be managed? And also risk for impaired skin integrity, that this patient might actually develop decubitus ulcers. So think of how you're going to manage these particular problems. What are some of the complications that may arise, especially particularly due to bacterial meningitis? The patients may have seizures, okay? And this, of course, will occur just from the pathophysiology. You are able to relate all these complications, okay? So our patient may have seizures that would develop from the inflammatory process. Remember, release of glutamate and aspartate. Okay, our patient may end up with seizures. Then also this patient may end up with cranial nerve pulses. Okay, if cranial nerve number 3, which is the oculomotor, is affected, then we are likely to see, for example, drooping of the eyelids. The patient will have problems moving the eyeball, okay, because cranial nerve number 3 is affected. So it's usually cranial nerve number 3, that is the oculomotor, okay, the trochlea, the abducens, and the facial nerves that may actually be affected with meningitis. Subdural effusions and cerebral edema. We've talked about the various forms of edema that will occur. And then when the edema is severe, we may end up with transtentorial herniation, okay, herniation of the brain where it is pushed through the foramina, and this may lead to brainstem damage and death. Patient may have, because of the accumulation of CSF in the ventricles of the brain and increased intracranial pressure, patient may have non-obstructive communicating hydrocephalus, okay? And this will manifest in the form of obtundation and mental retardation. This patient may also end up with an ischemic stroke, okay? Because remember, we had talked about damage to endothelium, which becomes more prone to thrombosis. Remember that the neutrophils are also blocking these blood vessels. So when blood flow to the brain is reduced, basically you end up with an ischemic stroke. This patient may also end up with a hemorrhagic stroke. High blood pressures. Okay, high blood pressures more easily cause the fragile vessels to rupture, and your patient may end up with a hemorrhagic stroke. And with stroke, they'll end up with hemiplegia or hemiparesis, seizures, okay, among the many complications that may occur. Then patient may end up with a brain abscess if the bacteria gain entry to the brain parenchyma and then they are localized within one area and the pus or purulent material is covered within a fibrin membrane, then that becomes a brain abscess. Okay, and you're going to look at the other complications that may occur with meningitis. Okay, so this is where we end with meningitis. Please, for any questions, you know how to contact me. Thank you.